Firstly, I want to thank the organizing committee for the invitation, and I want to thank all of you for being here on a Saturday morning. My presentation is about how we can integrate basic research and clinical practice in endourology training. So I will start with some definitions. What is basic research? Basic research is a type of scientific research that asks fundamental questions and tries to understand how nature works. There's also the translational research, which is the research of the practical application of the knowledge generated by basic research. And then there is the clinical research that explores whether the new treatments or the medication or the diagnostic techniques are safe and effective in patients. Now, the definition for clinical practice is any work undertaken by a doctor that relates to the care of an individual patient. Clinical practice should be based on clinical practice guidelines, and these guidelines are defined as statements that include recommendations made through systematic review on evidence and review on benefits and risk of treatment alternatives to optimize patient care. Fortunately for us in urology, we have many guidelines. The most commonly used is the EAU guidelines and the AUA guidelines. And I'm going to start with the role of the basic research in the residence training. We all know that as practicing physicians, we're expected to apply into the care of the patient evidence-based medicine with continual integration of new clinical evidence. Despite this emphasis placed on the evidence-based medicine, medical education is far from evidence-based, and to be honest, urology is a specialty where the medical education research is particularly sparse. Why is it important for us to integrate basic research in the training of residents? For three reasons. First, involvement to basic research will foster understanding of basic scientific concepts. Secondly, it will improve critical thinking and critical performance. And third, the future urologists may contribute to scientific discoveries. So to ensure that the field of urology is driving forward, we need to expose more trainings to research, and that is why the AAU has a dedicated section for urological research that covers basic and translation research in all areas of urology, including endourology. And also has the EAU Research Foundation to promote, facilitate, and stimulate basic and clinical research. So what are the challenges? What are the barriers? Why haven't we done that yet? Until recently, only 18% of urology residency programs in the US offered a year of dedicated period of research time. And to be honest, I couldn't find any data for what is happening in Europe. So the barriers. The first barrier is obviously money. Funding of the salary of the resident during a pure research period is generally not available. The second barrier is time. We all know that training to become a urologic surgeon is demanding. Additional time dedicated to research during a residency program is a luxury that many residents do not feel is justified. The third barrier is dedicated space for the support of these activities. And the last barrier is the lack of research mentors. So what can we do? We need to bridge the gap between basic scientists and clinicians in order to advance our understanding of the pathophysiology of urological diseases. There must be an enhancement of the educational culture to support an understanding of the importance of learning research methodology and biostatistics. How can we do that? Regarding time, research should and can be performed before or during residency, during a fellowship, or within a master or PhD program. The extent of research performed by urologists in training has to correspond with his career path. For some, maybe a short exposure would be sufficient to understand the basic concept, while for others, several years of research might be required to learn good research practice and to initiate promising research projects. For the lack of mentors, we need to develop mentorship, and that needs to occur at all levels, in the department, in the institution, and national as well. For this barrier of space, the institution should ideally provide the research space. And for the money, again, the institution should try to secure government training grants. Now, about the second part of the presentation, clinical practice. Clinical practice in endourology can be divided in non-technical skills and technical skills. These skills can be obtained by using the traditional mentor-apprentice model and simulation-based training. So what are the non-technical skills? These are the cognitive and social abilities that complement a clinician's technical ability. You can see here in the slide that there are cognitive skills, social skills, and personal resource factors. With non-technical skills deficit being recognized as a major cause for error in surgery, there is an increasing interest in their training and evaluation. A growing number of training courses are emerging, and some non-technical skills curricula have also been created and validated. So, how can we train someone to have these non-technical skills? This can be done in three ways. There is the cognitive training, which is a low-cost approach and involves mental rehearsal of the task with the aid of a script. There is the classroom teaching, which includes observing famous incident and video analysis of self-performance. And there is also the simulation, which is the most effective way to train someone in non-technical skills, and I'm going to analyze it a bit more in the next slide. So, for the simulation, the type of simulations are divided into three main categories. There is the full immersion simulation, which consists of an inflatable and mobile glue shell filled with operative equipment. There is the high-fidelity simulation, which uses simulated OR, but this is particularly costly and can be restricted only to bigger centers with better resources. And finally, there's also the crisis resource management and ward-based scenarios. This has been used by emergency teams, but it can also be considered for urological training as well. There are also some tools that can be used for NTS assessments. These are, and there is one especially for urological surgeons, the non-technical skill for urological surgeon tool. Finally, there is also, as we said before, the technical skills. The closed cavity nature of endourological surgery means that it is well suited to simulation training. As a result, many training simulations have been produced in the last 20 years. The available simulator, you can see here, there are the virtual reality or augmented reality simulation, the benchtop or 3D printed models, the animal tissues, live animals, human cadavers, full immersion simulation, and high fidelity operating room simulation. All of them have advantages and disadvantages. And here is a list of all the available training models I could find. Maybe I'm missing some. There is also tools for the assessment of technical skills. The most commonly used is objective structure assessment for technical skills, the OSAS. We talked about simulation and technical skills, but do we know if it actually works? Recently, we obtained level 1 evidence that simulation training has the results that we expected. As the Simulate trial was published, this is a multi-center randomized trial which aimed to evaluate whether surgical residents who undergo additional simulation training are able to achieve proficiency sooner and with better outcomes when compared to standard OR-based training. So what happened was 94 residents were randomized to receive either OR-based training only or OR-based training plus simulation-based training. As you can see here, The group that received simulation-based training as well achieved proficiency to flexible ureteroscopy sooner and had lower surgical complication, and that includes major complications. So, to conclude, now we have an opportunity for improvement and innovation in both quality and efficiency of endourology resident education. Incorporation of basic research and simulation training into formalized and validated curricula is required to advance this opportunity. Thank you.